Welcome to Clinical Challenges in the Assessment and Management of Hepatitis C, a two-part educational series presented by the Penn State College of Medicine at ID Care Live. Today is the final segment in this two-part series, and our first session is titled Advances in the Treatment of Hepatitis C, the latest on new and emerging antiviral regimens with Dr. Arthur Kim. My name is Susanna Nagy, and I'm an assistant professor of medicine at Duke University School of Medicine. The activities in ID Care Live are interactive, allowing us to take your questions in real time throughout the presentation. We encourage you to enter questions at any time in the box located at the lower left-hand side of your screen. I'd now like to introduce our presenter, Dr. Arthur Kim, assistant professor of medicine at Harvard Medical School. In addition, he's pleased to serve as the course chair for this important educational series. Arthur, thank you for joining us today. Let's get started.
Great. Thank you, Susanna, for that very kind introduction. And yes, we do encourage interaction from the audience, and so we hope to hear from you, your questions, as we go through this. Right now, we're in the midst of a therapeutic revolution in hepatitis C. It's really the most rapidly changing field in medicine over the last year or two. And so we look forward to discussing what's now available after the last couple months, and also a little bit of what's in the future for the antivirals. Of course, we could cover many topics. We could cover treatment of many different special populations, such as those with HIV or those with renal disease or whatnot. And unfortunately, we may not have enough time to do everything. So we will focus in on the antivirals and how they work, and hopefully many of you will receive something from this talk. These are a few disclosures that I have. And of course, I will be discussing off-label use in this presentation at times, and I'll try to point that out when that occurs. So first, just briefly, the natural history of hepatitis C, and many of you will be familiar with this. After an acute infection, it's important to point out that people can clear the infection on their own, and so they'll have a positive antibody and a negative RNA. And of those who go on to chronic infection, it's also important to point out that many will not necessarily suffer from the downstream complications too much. They will have what we call stable or slowly progressive disease. Then there are those who progress on to cirrhosis, and cirrhosis is not something that we want our patients to have, because then they are at further risk. Their livers go from a sort of soft state, so to speak, to a hardened state, and then they suffer physiologic consequences. They suffer risk from cancer. And one could quote that risk of cirrhosis typically at 20% over 20 years, although it's so variable between patients as well. So you'll have some patients who progress more rapidly and more patients who have 30, 40 years of infection and yet do not have yet cirrhosis. But once they have cirrhosis, then they're at risk for liver failure, for hepatocellular carcinoma, which continues to rise in incidence in our country, largely driven by the hepatitis C epidemic. And, of course, death. Now, the items that we believe accelerate this process include regular alcohol use. So we do advise patients to minimize, if not cut out, alcohol, especially if they're in the cirrhosis state. Non-alcoholic steatohepatitis, or NASH, so not gaining too much weight and adding fatty liver on top of hepatitis C. And then co-infections, such as HIV and hepatitis B. These are these are infections that can then accelerate the progression. So those individuals who are co-infected are probably more highly prioritized for treatment because of this accelerated progression that can occur. What are the goals of hepatitis C care? There are many. And we'll focus today on viral eradication. But it's important to point out that care does not just involve antiviral drugs. It involves counseling. It involves counseling about preventive measures that can reduce transmission. It can talk about identifying symptoms that could be referable to hepatitis C. These include things like fatigue. They include things like rashes due to cryoglobulinemia, and those patients might also be prioritized for treatment. All along, we want to delay fibrosis progression, as we discussed in the last slide, and we want to prevent really those downstream complications that threaten really the lives of our patients. And rarely, you might need to treat the hepatitis C, which is associated with an increased risk of hepatotoxicity, and that's particularly true in HIV, but also sometimes in other conditions, such as co-treatment with TB, tuberculosis. We also, all along, want to maximize the patient's quality of life. But now we'll go back to viral eradication, which clearly is associated with reduced all-cause and liver-related mortality. It's interesting, other studies not shown here do show that patients with hepatitis C, on average, may lose up to 20 years of life compared to their hepatitis C negative counterparts. But here what you're looking at are survival curves, or that describe the mortality on the left, as well as specifically liver-related mortality on the right. And these studies follow patients who already have advanced fibrosis or cirrhosis, and what happens if they were able to be treated and achieve what we call a sustained virologic response. And that sustained virologic response, which is defined now as a negative RNA after at least 12 weeks of treatment, what you see here is that those who achieve SVR have radically different courses. Their mortality is lower, their all-cause mortality is lower. And you can see on the right, a lot of that is driven by decreased liver-related mortality. Another item embedded in this slide talks about those with advanced fibrosis or cirrhosis who did not achieve SVR. We call those patients treatment experienced, and that will be addressed in the next hour, which we hope you'll also be able to join us for. And there you see a 5-year mortality rate without SVR of around 10%. So oftentimes we're talking with our patients with cirrhosis. They believe sometimes that it's oh dear, I'm really, really at risk. It's true that many patients can remain stable with cirrhosis. So, but they're also at risk. So it's kind of a mixed message there where we really want to both reassure patients if you're well cared for and stay in care, we can prevent those complications. And yet also we really need to prioritize you to get that SVR.
Right. So would you make a comment briefly then? I think this is a great opportunity to talk about. So when you take your patients, many of us are treating patients with cirrhosis right now, prioritizing getting them in to get them access to treatment. Once they achieve a cure, which many of our patients will, what do you tell them regarding their monitoring from here on out? So, I tend to tell patients once a cirrhotic, always a cirrhotic, at least for now. I usually draw these Kaplan-Meier curves for them, telling them that, your risk is dramatically different from the day you're cured, but it doesn't return to a normal baseline for approximately 10 years. And I give them the example of, smoking and lung cancer, and when we stop worrying about a smoker who stopped smoking.
Yeah.
What do you do for these patients in that period to continue to ensure they don't develop HCCs? What is your monitoring? And even, do you think about doing additional fibro scans or something to assess them for what people would call regression? And do we have any information about that to help us understand?
These are great questions, and I'm sure the audience has this on their minds because you have patients now who are cirrhotic or have advanced fibrosis, and you're thinking, well, what do I have to do for these patients in the future after cure? And we're going to have more patients that we're managing after cure. And so I can also couch it like the way patients do. They often ask several questions like, Doc, what percentage of my liver is gone? Absolutely. And we don't have that sort of information for them. But what we do have now are tools that can define cirrhosis a little bit better. For instance, the FibroScan that you're referring to, yes, they can define cirrhosis or not, but they also define the risk of complications beyond. So if your FibroScan shows cirrhosis, there's kind of cirrhosis minus, cirrhosis plus, and that can help define things. The patients also ask, Doc, can my liver heal afterwards?
Right.
And I do think that can occur. There have been studies that show that if in biopsy studies after SVR. However, it's important to point out that patients with advanced fibrosis or cirrhosis also have scar. And scar is associated, I think, with cancer or cancer risk. And there, I think most hepatologists at this time would recommend that we continue screening with sort of at least 6-month ultrasounds to look for those HCCs. Now, can we define subpopulations in the future where that risk does decline? I think that's the subject of future study and will be very important in the coming era.
Right. So continued HCC screening with at least 6-month ultrasounds, continued lab testing to assess one's MELD score and Child-Pugh status every 6 months would be the minimum. And then additional screening for things like varices would really be based on one severity of portal hypertension, which is generally recommended every 2 to 3 years until varices are detected and treated. And I would just take one step back with a question from the audience to say that SVR stands for sustained virologic response.
Yep.
So this is what we would kind of consider the virologic surrogate for cure.